And a lot of activity in the field of thrombophilia diagnostics or diagnosis when the knowledge was evolving in the late 80s and 90s, thanks to the contribution of several pioneering work done by a lot of people in the Scandinavian area, led by Dr. Rosendahl and Dahlback and et al. And so many of them. And as happens with many of the new concepts and technologies and ideas, that there is somewhat indiscriminate use of these ideas or practices in the beginning of the implementation of these ideas or these practices. And then the dust settles sort of. And people realize the pros and cons of all that they have done till now. And as a result of which, then the guidelines come out and recommendations are made, and things get more streamlined and are more scientifically justified than what they would have been earlier. And this happens with, or has happened to many of the concepts and technologies in medical science. So nothing surprising there in terms of what happened here. So my job today will be also to, because I assume that there are postgraduates in the audience and students, to give you a little brief background of what thrombophilia actually means, what are its the various interplays of the various factors which ultimately lead to increased tendency for venous thrombosis, and then get into the area of the current concepts, which is what I was just now referring to. So a very basic thing that thrombophilia, the term itself or the word itself, means increased affinity for thrombosis. Some workers use this as a synonym for inherited increased tendency. So I don't think that's the right way of explaining or describing thrombophilia. So according to me and most of the people in the field, it is both inherited as well as acquired tendency for increased thrombosis. Now, as students, we used to wonder, and in fact, sometimes in our exams, our teachers used to ask, why do you think blood is in liquid or fluid state? And we would not know, obviously, all the details. But as you now understand, and as shown by the advances in the understanding of hemostatic mechanisms, that there are two counterbalancing forces in the body at any given point in time. One force or one component is what we call as the prothrombotic forces, which is shown here on the right side. And on the other side, or the other arm, are the antithrombotic forces, which have, each one of these have two components. The thrombotic forces are neutralized by the natural anticoagulants, and the fibrin that gets formed as a result of the continuous activation of the activated coagulation factors as a normal phenomenon in the body, that gets neutralized by the fibrinolytic pathway. And as shown here in a very simplistic way, that the one on which inhibits or lyses the fibrin or inhibits the fibrin formation or thrombin formation has a greater say in the state of affairs than the thrombotic processes. And therefore, we have, as the nature has provided, liquid form of blood in circulation. Now, when do you suspect thrombophilia or increased tendency to venous thrombosis? It's listed here, nothing new in that, except for the last 2 points, which I think we need to keep in mind, that is something which now we realize that in the obstetric field, the cases of recurrent fetal loss and other complications of pregnancy tend to get caused by Aplar syndrome. And therefore, that constitutes one of the indicators, or these symptoms or signs constitute one of the indicators for investigating these cases for possible Aplar and therefore thrombophilia. This is a depiction of the concept that was proposed, in fact formally proposed by Rosendahl in a beautiful article in Lancet many years back, and that is, and that has been proven to be correct, is that you can have inherited tendency to thrombosis, you can have acquired causes for thrombosis, but by and large independently, if you have monogenic defect in the on the inherited side or the acquired also, you don't normally have a thrombotic episode spontaneously unless there is an interplay between these factors within the group or in between, that is between the inherited and the acquired. And this is proven now by multiple examples, and is something which as a concept, as I mentioned, was proposed many years back. And VTE, venous thromboembolism, is the outcome of this kind of an interplay. This table lists the common or well-known inherited, acquired, and the unknown or mixed etiologies for hypercoagulable state. I have highlighted the ones which are important in the context of investigations for these cases. That is Aplar syndrome in the acquired area. On the inherited, in the inherited arm, it is the antithrombin deficiency, which is known to be associated with greater risk and higher risk of recurrent thrombosis. Prothrombin gene mutation, as people in the field would know, is not seen by and large in the Indian population. And therefore, that is something which we should keep in mind and not indiscriminately investigate cases of thrombophilia for this defect in the Indians. Factor 8 in the last column, second item, till recently was considered to be either inherited or acquired elevation was considered to be an important factor for both venous as well as arterial thrombosis, but the recent analysis of cases and as advised by the British guidelines for thrombophilia investigations, these are not clinically significant, or the linkage has not been established, and therefore it is dropped from the list. Now I'll show you one or two cartoons in which it's again for the new entrants in the field, and that is the protein C pathway, or thrombomodulin protein C pathway, which has multiple aspects in terms of its in terms of its mechanism as well as outcome. Now, as shown here, on the left you can see endothelium, and then TM stands for thrombomodulin. So whenever endothelium, of course, is a rich source of thrombomodulin, thrombomodulin is expressed on the surface, and its secretion increases if there is an endothelial injury. And that attracts thrombin, and therefore there is a formation of thrombin-thrombomodulin complex, which is happening all the time. As I said, there is a continuous process of thrombosis going on during the day-to-day activity in our bodies. But the defense mechanism or built-in safety mechanism is the fact that this complex then, in the presence of protein S, activates protein C into activated protein C, or APC, and that in turn inactivates activated factor 5 and activated factor 8. And it is here that the mutation of this particular factor in factor 5 Leiden and then some other variants is where the activated protein C is not able to act, and therefore you have uninhibited activity of activated factor V and therefore increased tendency to thrombosis. And similarly, a mechanism theoretically should be operating for factor VIII as well. There are some anecdotal reports of this, but it is not recognized as a cause. Why that's the case, maybe somebody else can throw some light on that. The other abnormality which I highlighted as an important etiological factor for inherited thrombophilia is antithrombin deficiency, and this shows why it is important. Why is antithrombin important? As you can see here, it is acting at multiple sites, including thrombin, to inhibit these activated factors. And therefore, these are called natural inhibitors of coagulation, and that's how they act. And therefore, in deficiency of these proteins, you have uninhibited activity of these factors, and this ultimately leads to thrombin formation and thrombosis. Now, this table shows you, this is a little older data, but the recent data also confirms the kind of incidences of these deficiencies. Here we have listed the antithrombin, protein C, protein S, factor V Leiden, prothrombin gene mutation. These are all inherited causes of thrombophilia, and these are the acquired ones, that is lupus anticoagulant, anticardiolipin antibody, and anti-glycoprotein 1 antibody. And as you can see here, the incidence of antithrombin deficiency, both in terms of relative risk of first venous thrombosis as well as recurrence of thrombosis, is the highest amongst the inherited thrombophilia factors. And again, lupus anticoagulant as well as anticardiolipin antibodies are similarly implicated as important contributors to acquired thrombophilia. This I'll skip. I think most of you know already about that. The point I wanted to make here is that unlike the other two where you have quantitative and qualitative deficiencies, in the case of protein S, you have an additional type because of the fact that you have the active form of this protein in circulating or free state. So this is something which we measure in our labs to measure the available protein S activity. Now, coming to the questions that come to mind as one confronts a patient of thrombophilia or DVT or pulmonary embolism, in terms of the management, when it comes to investigating these cases, we need to answer these questions, and these are listed here. Should thrombophilia testing be performed to help determine duration of anticoagulation following provoked venous thromboembolism? And in my subsequent slides, I will try to address these questions and these doubts. Should thrombophilia testing be performed to help determine duration of anticoagulation following unprovoked VT? And provoked and unprovoked terms are used basically to indicate a known etiological factor in the genesis of thrombosis, while unprovoked means you don't have an obvious thrombophilic factor, and therefore possibly you need to investigate these cases more than the ones where you have clear-cut etiology for thrombosis. Should family members of patients with VT or hereditary thrombophilia undergo thrombophilia testing? Should female relatives of patients with VT or hereditary thrombophilia who are considering using estrogen-containing medications be tested for thrombophilia? Should female relatives of patients with VT or hereditary thrombophilia who are contemplating pregnancy to be tested for thrombophilia? And finally, if thrombophilia testing is to be performed, at what point in the patient's care should this be done? Now, these are very practical and important questions, and that is how, when you try to answer these questions, you realize that there are very few situations where indeed, in fact, you need to...
There's only five more minutes left.
Only 5 minutes?
Total, you have finished 15, so we are into the territory.
All right, so I think I'll have to go rush through the presentation. So let's see what are these. So in this table, you can see on the left-hand side, it clearly says that you don't do testing in these three conditions. That is, you do not do the testing at the time of the event, you do not test while patient is receiving anticoagulation, that, no prize for guessing that, why that should be, and do not test if VT is provoked by strong risk factors. And this is very clearly shown in patients, and in fact we published some data as well in patients of lower limb arthroplasty, where you have very high incidence of venous thrombosis, and in spite of these patients receiving heparin. And we have shown that whether the patients thrombose or don't thrombose, they do not have any inherited thrombophilic factor. And that is very important information, meaning thereby that these are due to the process or the procedure that these patients undergo. And therefore, the question of investigating them doesn't arise. And this is a very important analogy for other situations where you have this kind of a scenario. But consider thrombophilia testing in patients in whom VT occurs at a young age in association with a weak provoking factor, meaning thereby there are situations where the provoking factor is not a strong provoking factor, and or a strong family history of VT with inherited thrombophilia or those having recurrent VT. So this is a clear indication of testing for thrombophilia. But it is also important simultaneously to identify the objective, why you want to investigate. And there are three examples wherein you would like to do thrombophilia testing.
Can I just let you know that we are now in the question territory, so we'll have no time left for questions.
Okay, so, quickly, can I get a minute's extension?
That's okay, yeah, that's fine.
So this is where it is, and I think this is what is also showing the same thing, which is that you have provoked VTE, you do not do any testing. In the next two vertical flows, you do testing after you have determined the objective of testing, and then of course you have the whole gamut of things that you need to do. Very importantly, you need to investigate patients who come with unusual site venous thrombosis like cerebral vein or splanchnic vein, where also you do the testing. And in the case of splanchnic vein thrombosis, you need to investigate for myeloproliferative neoplasm and PNH as well, because those are known to be associated with this entity. Now, so this is a point which I just wanted to bring across, which is that there are a lot of situations where we get pressurized to do investigations in these cases, and there is a way out of this situation wherein you can do two-stage testing in patients on anticoagulation, and these are the tests which are not, or tests which are not influenced by anticoagulation or venous thrombosis, while the other tests you cannot do. And so this shows you the panel that usually used to be prescribed in these patients earlier, but now we have reduced it to from 14 items to maybe 6 items, wherein very clearly you need to do these investigations and not go for the additional tests. This is the two-stage thing which I mentioned. You can do factor V Leiden, prothrombin gene mutation, and these antibodies, because these are not influenced by any of intervention or venous thrombosis, while these investigations, which are coagulation assay dependent, cannot be done. And I think I'll skip that. And this is finally the slide that I wanted to show, which shows the trend. And therefore, in the pre-90s, we had a lot of investigations for antithrombin 3, protein C. At that time, it used to be called antithrombin 3, protein C and protein S. And high incidence of these deficiencies were being reported, and therefore that led to more and more patients being investigated for these investigations. While today we hardly do any testing, and we do that in the very specific areas which are shown here. This is usually drifting away from the venous thromboembolism cases, other than those which I showed in the flowchart, to more arterial thrombosis and pregnancy-associated thrombotic events than anything else. And just two more slides, maybe just quickly to say that the reason...
we'll have no time to ask any
Okay, so I
questions.
think I'll stop here. I think I have done this. This is just to show that the labs which do the investigations do it on the frozen samples. And that causes reduction in the levels of these proteins. And labs, even good labs, cannot do these assays on a daily basis. And therefore, you need to freeze. And you tend to report higher incidences of deficiencies on these frozen plasmas. And that was the reason why I suppose the incidence of these deficiencies were reported to be higher earlier. And once now the awareness is there, those things have gone down. So I think I'll stop here. Conclusion is just repeat of what I have already said. So thank you for your attention.
Thank you, Dr. Dasgupta. We have time, just about time for 2 questions. If there are no questions, I've got one comment to make. You've got a question? Yeah, okay.
Excellent talk, sir. I have a small question that is related to the newer anticoagulants. Suppose the patient is coming on newer anticoagulant, what is your approach? How you are dealing? Will you do the testing or we will wait?
Yeah, good question. Newer anticoagulants is a new phenomenon. The good thing about that is that these are usually very short acting. And therefore, depending on, as I mentioned, if you want to go for one investigation, a gamut of investigation at one time, you will have to wait till that effect goes. But you can do it, because unlike oral anticoagulants where you have to wait for weeks together or even months they recommend, in the newer anticoagulants that advantage is there. And therefore, one of the reasons why people would like to use newer anticoagulants, because they are short acting and the complications are very few, you don't need any monitoring. So that is the answer, but you can also do 2-stage, because the impact of that, of those drugs on the, the assays would be the same, whether you are using oral anticoagulants, the conventional or the new anticoagulants. The outcome will be the same, and therefore the precautions will be also similar.
Thank you, sir. One more question, sir.
Can I just interrupt you? Sorry, sorry, I've got to stop you. I'm really sorry about this. We've got 2 others. So 2 more questions, and after that we have to stop.
Sir, an excellent presentation. I just want to know one thing. Many of my clientele, they develop thrombosis, and the story is like they are lowlanders. They are staying at high altitude, more than 10,000 feet from sea level for a few months, and then they'll end up with thrombosis. So in these cases, usually the treatment, my algorithm is that I ask them to not to be placed at that high altitude again, and I give them 3 to 6 months of anticoagulation, and I usually don't test for any of these related thrombophilias. Is it correct?
Because you know why that is the case. I mean, you know the reason for thrombosis. There is a lot of work that has been done by Indian Armed Forces, our colleagues in FMC as well as in the Armed Forces, on the high altitude cases of venous thrombosis and pulmonary embolism. So that is known, that association.
So you agree that that is a strong...
so there is no indication for investigating these cases.
Thank you, sir. Thank you.
Sir, I have a quick question. Very nice talk. And I just want to ask, like, in addition to routine thrombosis, when we have an unusual site or arterial thrombosis, like in the case of PNH, then what is your approach when you put the patient on anticoagulant? You know, the clone is going to be strong and is going to be lifelong, and it's difficult to treat underlying cause also. So what is the duration of anticoagulation in that case?
I'm sorry, I didn't get exactly what you want.
Sir, like normally anticoagulation, even if extended, we put for like 6 months to 1 year, or 1 year to 1.5 years, maximum 2 years. But like in PNH, like what is the duration when the clone is, like in MPN kind of cases, we can shift the patient on antiplatelet after, anticoagulants. But what should we do in the case of PNH? Like,
so in fact, we had a talk earlier in the day, and this point came up, and the speaker did mention that these are lifelong things. I mean, you cannot really stop in between unless you control the disease in a manner where the the hemolysis is controlled. So in that case, maybe one can look at the possibility of discontinuing or reducing the dose and things like that. But otherwise they will have to be on.
So again, risk versus benefit, because otherwise the risk of bleeding increases after a year, but otherwise risk of bleeding is not very high in PNH cases, I believe. Thank you.
Thank you, Dr. Amardas Gupta, for a very useful and good talk. And this coagulation is also a major part of our bread and butter for hematologists. You want to say something?
Yes, sir.
Yes.
So, there's a parallel session that's going on of transfusion medicine in the APC hall, so anyone who's interested can please proceed.
Now, the second speaker, we have Dr. Jyoti Kotwal, and she's speaking on a very important topic, that is postpartum hemorrhage management and clues for the ROTEM.
Thank you, Dr. Reena and Dr. Jasmeena, for having me here. It's a pleasure always to be here in this hall and meet the people and talk something. So today I'm going to talk about PPH management, clues from ROTEM. So everyone knows what is postpartum hemorrhage, more than 1,000 ml loss with signs of hypovolemia, and we all know they can be primary PPH within 24 hours. Secondary, it is one of the top 5 causes of maternal mortality, and in our country, it is very, very important. Now, when hemostatic monitoring for postpartum hemorrhage was done, it was found that 70% of the cases are because of loss of tone. Another 20 are because of tissue, that means placenta accreta, placenta abruptio, placenta previa, etc. Trauma accounts for 9%, and it is only 1% because of inherited bleeding disorders or some DIC which is there. But in all these, the major coagulopathy which has been seen is low fibrinogen levels, and it has been seen whatever the cause, if the PPH is not controlled or the cause is not controlled, they go into a coagulopathy, and the main problem there is low fibrinogen. Now, before we go into the ROTEM, just to understand, pregnancy is physiologically different. It is a prothrombotic, it's like a chronic compensated DIC state. So the platelet counts maybe till 70,000 normally. The factor 8, von Willebrand factor, Recov factor 10, 12 are increased. Factor 7 is increased 1,000 times. Fibrinogen is 200%. So the normal range of fibrinogen in pregnancy is higher. It is 4.4 to 7.2. Protein S functional and as well as total is low. Protein C and antithrombin are normal, but some of them may have acquired activated protein C resistance, and we all see that APTT and PT are always shortened in pregnancy. Fibrinolysis is also altered. There is a 3-fold increase in Pi1, and also Pi2 comes, plasminogen activator inhibitor 2 comes in from the placenta. There's increased plasminogen, alpha-2 antiplasmin, and there is increased D-dimer. So we have to remember that the D-dimer in a normal pregnant woman in the 3rd trimester can be 4 times the normal value. So it doesn't mean that the woman is in DIC. So someone is bleeding, you do a D-dimer, it is 2 grams per deciliter or 2,000 FEU, oh, the patient has DIC, that's not correct, because it's physiologically a different condition. So a lot of data came in, and it was realized that if fibrinogen is less than 2 grams per deciliter, it is 100% positive predictive for severe PPH. And if it is, so it is normal 2 grams for normal people like us, but in pregnancy, it is 100% positive predictive for severe PPH. And if it is more than 4 grams per deciliter, then it is 79% negative predictive for PPH. So this is very, very important that we all know this and tell our gynecology and obstetric colleagues about this. So the ISTH scoring for DIC does not work. A pregnant woman, postpartum hemorrhage, the DIC score of ISHTH does not work. The platelets, the shortened PT, APTT, so you have a high D-dimer, you think it's DIC, it doesn't work here. The platelet count doesn't work, and the fibrinogen cutoff of 100 does not work. It's a cutoff of 200 for severe coagulopathy. So, people started looking at the association of fibrinogen, and what was found that fibrinogen level at the time of PPH is the marker of risk of aggravation and further blood loss. Another study which found that it is the best parameter which correlated with the hemorrhage, and most of this work was done by anesthetists and critical care specialists. obstetricians handed over the patient to the critical care specialist, and hematologists were generally not involved initially. So they went into newer approaches. So if it is fibrinogen, can we have a faster report of the level of fibrinogen? Through viscoelastic testing came into account, so people worked with TEG. There's been a lot of work with TEG all over the world. And then this new thing called rotational thromboelastometry came up. Now here there is a separate parameter called FibTem. And if you take the reading at 5 minutes, so within 10 minutes of collection of the blood sample, you have a reading, it tells you, and it was found to correlate beautifully with the fibrinogen level with a R squared of 0.75. So taking this into account, and we just got a ROTEM in the last months of 2018 in our laboratory, and we were doing some work on hemophilia and inhibitors and trying to see if it can help us see why severe hemophiliacs, some of them bleed and some of them don't bleed. So we were looking at the ROTEM, and we had this first patient where we looked at PPH. So this lady, she was wife of a doctor, underwent a delivery as an LSCS in Bhagalpur. And then she had 3 days, 4 days normal. Then she had AKI. They realized that she had some bleeding. They found that she had retained products of conception. They did a DNC. She settled down. And another few days later, she came to our hospital. That was almost 12 days after her LSCS. And at that time, her hemoglobin was fine, TLC was fine, platelets were more than adequate, and peripheral smear was essentially normal. 2 days of dialysis, and she suddenly developed secondary PPH. Her uterus was bulky, there was a huge hematoma, and it was a scar hematoma, so it was the trauma part which was causing it. So they did a DNC, they removed the products of conception, she lost 2 liters, and her HB crashed from 10.8 to 6.8 grams. So in that time, our OT used to have the TEG, so they thought they'll do the TEG because everything was normal. Her PT, APTT was essentially normal. You can see the report, 14.7, and APT 32.5 seconds. Platelets were just 97,000, so that was not the cause, and they did a TEG. Now, if you look at the TEG, there is R value, which is equivalent to the clotting time of ROTEM. We'll come to the ROTEM. So that was normal. The kinetic time was normal. The alpha angle was normal. The maximum amplitude was normal. And the percentage lysis was not increased. So it was a normal TEG. And that is the time we ran the ROTEM for this patient. So the advantage of ROTEM is for the TEG, you have to take the sample in a syringe and run to the site of the TEG because it should not clot. It's a whole blood which is run. Whereas in ROTEM, it is a citrated sample, so it comes, you can run it, and the same sample can be later centrifuged to get a PPP, and you can do the coagulation-based test on the same sample. Now, if you look at the value here, this is the XTEM, extrinsic pathway, intrinsic pathway, and this is the FibTem. So this reading comes at 5 minutes, A5. So A5 in the XTEM is 35, the cutoff is 35 or less, you have to worry. And this is the FibTem. So this tells about fibrinogen forming the clot. I'll explain it. So it was 8 mm. Now, in pregnancy, because the fibrinogen is higher, the normal should be 16 to prevent bleeding, and anything below 12, one has to worry about as per the data. So here it was 8 mm. So we said, okay, let us validate our data. So we did the plasma fibrinogen. It was less than 2 grams per deciliter. D-dimer was 3,720 FEU. So it was still not DIC, but PT-APTT was normal. It was hypofibrinogenemia. Now, at that time, to convince people who were used to giving, everyone is used to giving 1:1:1, all the data of massive transfusion, which has come up from the military data of giving ratio of blood transfusion 1:1:1. So they wanted to give FFP, patient got transfusion, FFP, and we tried to convince them, please give cryo, so mega cryos, and we could, there was a stage when they wanted to do a hysterectomy. She was in a very bad shape, and she was on a CCRT, and we could save her. And just to show you the FibTems on the same day, initially they were not ready to give cryo. We could take it up to 11 mm, we took it up to 14 mm, and she stopped bleeding. So this is within 24 hours. Midnight, we did the ROTEM, we could convince them. So TEG I told you about, and this is ROTEM. ROTEM has the advantage, it's a citrated sample, you don't have to run with it. Both have the same principle, it's a cup and a pin. So one, the cup rotates, in the other, the pin rotates, and there's a whole blood sample in between. And as it clots, there is impedance, and that is measured as an amplitude. So if you look at this, here we have the parameters of the TEG, and here we have the parameters of the ROTEM. So it's the clotting time, it's the clot formation time, same as the R and the K. The angle of from 2 millimeters to 20 millimeters is the angle of the clot formation, and then we have the maximum clot firmness, and here they have the maximum amplitude, and then there is lysis over a 1 hour time. So that's how ROTEM is interpreted, but we are just going to talk about PPH. So basically the clotting time and the clot formation time tells you about the coagulation factors, anticoagulants. Heparin will also increase it. The maximum clot firmness tells about the platelets and fibrinogen, and then there is the lysis. So it has various parameters. We generally learn 2 or 3, and we basically need to run XTEM and FIPTEM in PPH. So INTEM is with the lagiolic acid, tells about the intrinsic pathway. XTEM is with recombinant tissue factor, so it tells you about the extrinsic pathway. Now in FIPTEM, there is a platelet inhibitor, cytokinesin D, so it assesses the fibrinogen deficiency, blocking the platelet contribution to the formation of the clot. So that is where it is, and APTEM basically looks for correction in hyperfibrinolysis. So this is a normal ROTEM that you would get. So no lysis, and this is the FIPTEM. And this is what you would get in thrombocytopenia. The alpha angle becomes lesser. The amount of clotting is less, but the FIPTEM is normal. So you know it is thrombocytopenia or platelet dysfunction in a patient with PPH. Now for fibrinogen deficiency, this is here, it is very low. We had around 8, here it is a very low FIPTEM, and you can see this. So this, and with slightly increased A5 for XTEM would give. And this is a fish-like, this shows you hyperfibrinolysis. So any pregnant woman, anyone who's had PPH is having this kind of a picture, you know that she requires tranexamic acid because this is hyperfibrinolysis. And this is heparin effect. You see that the CT of the INTEM is increased and it gets corrected by HepTEM. Even without correcting, you can do other methods to know it. So now we come back to this patient. So this was the ROTEM of this patient. So A5 was 8 millimeters, XTEM A5. So we got the reading at 5 minutes. This is the whole pattern, but we took the reading at 5 minutes and the patient could be treated accordingly. So that means within 10 minutes of collection of the blood sample, you get it. Now this, what we started doing, and we did a big study later, was on the evidence-based ROTEM A5 PPH algorithm given by Dr. Guringer. And well, in this, in our hospital, every woman who delivers or has a LSCS is getting tranexamic acid as part of the women trial. But in many hospitals and many places in India, it's still not given. So first thing is, whenever there is a PPH, consider giving tranexamic acid. Then you look at the A5 amplitude of XTEM at 5 minutes. If it is less than 35 and the CT, fibrinogen, is not getting clotted, is more than 600 seconds, that means, or the lysis will come much later, is more, you have to give another tranexamic acid. Now, if there's a situation like what we had in our patient, and that's what we see in majority of the patients with PPH, we have our data now, less than 35 and FIPTEM less than 12, fibrinogen has to be given. Now, this fibrinogen is now, at that time we had only cryo when we did the work. Now fibrinogen is available in India, and you can calculate the dose for to increase 2 mm, you need to give fibrinogen 12.5 milligrams per kg body weight, and depending on the fibrinogen concentrate, it is 0.6 ml per kg, and cryo is 1 ml per kg, so basically 1 mega cryo would increase it by 2 mm, so one can calculate it. But if that is not there, this will be there in majority of the patients. If that is not there, then it could be a problem of thrombin generation. Look at the CT XTEM, and the FIPTEM is more than 12, so you know the patient requires either PCC or FFP at 10 ml per kg body weight. If the INTEM CT is increased, we know it's the effect of most probably heparin, or there's factor deficiency, so you can do a heptin, and look at the ratio, so treat it with protamine sulfate or just go in for FFP, and if the patient continues to bleed, it can be repeated. So this was the algorithm, and this algorithm was validated in this study where they found that A5 less than 12 mm was equivalent to fibrinogen less than 2 grams per deciliter. Now, different people have done their own studies. So this is the Liverpool Women's Hospital. Their guidelines say when there's a massive hemorrhage, start red cells and then run the FIPTEM and XTEM at the same time. Now, if the CT XTEM is more than 100 seconds, you have to start FFP, wait for the 5 minutes value for the FIPTEM. FIPTEM less than 12 and there's bleeding, give fibrinogen concentrate. Less than 7, even if there's no bleeding, give fibrinogen concentrate. Now, if it is between 7 to 12, you can go further. And with this, then people evaluated, does it help in severe PPH? And it was found, if point of care ROTEM is used, then the number of hysterectomies, blood loss, RBC transfusion, fresh frozen plasma, and hospital stay and ICU stay, all is statistically much, much lower. We did our study on 100 consecutive ladies. We did a pre-delivery levels of PT, APTT, fibrinogen, get our own reference ranges, and one our post-delivery, whether it was cesarean, and we had 16 cases of PPH. We did a correlation of the fibrinogen with our FIPTEM. We got a good correlation, and we also looked at the ROC curves to get our own cutoffs. And basically, we had reference ranges for all these, and we found less than 2 grams per deciliter fibrinogen was 100% positive predictive. Our A5 was correlating very well with the R-squared of 0.713. Our clot formation time and clotting time, if it was increased, had a negative correlation with fibrinogen. ROC curves to less than 2.79, 92% accuracy for PPH. And based on this, what I recommend, you all can make your own ROTEM PPH protocols. This is what kind of picture you can see pre,
Professor Kotwal.
and you can close with this.
Very beautiful paper, very original paper. Oh, yeah, already finished. Thanks a lot.
Finished in time.
Thanks a lot. Thank you very much. Very nice paper. Extremely, very happy. Now we have, yes, he wants Dr. Ashok Roy comment. Okay, please.
It's a fantastic paper because I am an absolute proponent of ROTEM. I have been using ROTEM for about 9 years now, and I will not use APTT-PT at all as a hematologist. I never use it. So all our hemorrhages, mostly it's in seromyxoma, where the patients will bleed over 2 liters if we don't correct them. We don't use fresh frozen plasma. I don't believe in fresh frozen plasma. It's a useless product.
Yes, sir.
I'm telling you.
It just causes fluid overload and a lot of...
Absolutely. Our experience is that please do not use fresh frozen plasma. It's a myth. It only causes dilutional coagulopathy, and you will end up giving more and more platelets. So we used to have our program in seromyxoma peritonei where the patients used to bleed over 2 liters. So we used to use fresh frozen plasma as our standard treatment. We didn't have ROTEM at those stages. So we used to depend on the clotting screen, which used to come about 75 minutes later, which is absolute of no use to anyone at all. So we learned our lesson, and we found that the more fresh frozen plasma we used, the more dilutional coagulopathy we got. And we ended up giving loads of platelets, and eventually we will give cryoprecipitate. So in 2013, we changed everything. We went to cryoprecipitate only, and we dropped our perioperative blood, giving red cells from 8 units of blood to 1.8 units of blood. But at the moment I finished our trial in 2018 with cryoprecipitate and fibrinogen concentrate using ROTEM only. Currently we are doing another project which is finishing next month. We have recruited 100 patients, so I am a great proponent of ROTEM. Please consider it. This hospital should really consider ROTEM, and it should be in the theatre. I will never use it anywhere else apart from the theatre because you have to make quick decision. We do not use euglobulin clot lysis time at all these days. We only use ROTEM to diagnose hyperfibrinolysis, and I'll rest my case for
So the issue is, in India, the gynecologists don't even get fibrinogen level done, let alone getting the ROTEM done. In 2018, when I started in December, I did this project. We presented the paper in the ISHTH 2020 to get the gynecologists. Now they are convinced. There's no issue. I have a ROTEM, and they don't want to understand it. They want me to explain it to them. So we have a ROTEM in the lab, and we have a live screen in the labor room. We have a live screen in the OT. So we have, and a live screen in the ICU. So we have started it now in the last 3 months. And to get my hospital, which is I was for 30 years in the army. Sir, I did a lot of work on high altitude thrombosis. I've got my publications in thrombosis research. But here to get these people to understand, and my own classmates who are sitting as professors in Harding and Mamsie, as gynecologists, to know that fibrinogen is required was very difficult. And even today, most of the people don't know that fibrinogen is more important. That is the saddest part. Even the government guidelines, when they make for medical colleges, say PTA, PTT chahiye. No one talks about fibrinogen in India. So it's so important that we convince everyone that fibrinogen is important. And if bigger hospitals, ROTEM is giving you a faster report. So that was, it was a great difficulty that I could manage to convince people. And in my hospital, at least now, we have the ROTEM for the critical care, ICU, and for the labor room. And we've just got a project, DRNB super specialty critical care thesis we are doing on ROTEM. This, with gynae, I got this thesis done. That's how I could do this work. So it's very, very important. And we just forget hemostasis. It goes into the background, maybe because it's not so, you know.
Okay, we have no cause. It's a really beautiful topic. Please.
Very nice, Jyoti, and very useful, clinically useful data. I just wanted to understand in terms of practical issues, because ultimately it's an assay, it's a test. What kind of daily quality control or calibration is required?
We are using
and what would be the variables that one should be aware of while interpreting the data?
Yes, sir. Sir, so we are still in the learning phase. He's an expert. We are in the learning phase. We are still, that is why I said in the same sample at the moment, for the PPH, we validated it. We ran 200 samples of complete coagulation profile in those 100 women, pre and post delivery, and we had 16 with PPH, and all 16 of them had hypofibrinogenemia, and the FIB10 correlated. So here we have validated it, but now what we are using for critical care, and now our cardiac people want to use, surgery people want to also start using it. People are getting excited, the liver people are excited, because especially if the PT-INR is high, and the patient is not bleeding, we look at the ROTEM and we tell them whether it is, so it's still a learning phase. That's why I wrote in my conclusion that a lot of people have to do more and more work. But yes, we are running the quality control as per the guidelines of the POCT. We are validating it with the standard test as per the international, because in India, there are still no guidelines in NABL for POCTs. The National Accreditation Board for Laboratories has no specific guidelines for POCTs. So we've downloaded the guidelines from UK, and we are following those guidelines, and we are validating it with our manual coagulation tests, as well as we are running the controls. But it's something, I think, it's a first in India, because the saddest thing, I started with ROTEM at that time. Fibrinogen also my hospital was not looking at. So it was first to educate the gynecologists and obstetricians that fibrinogen is important. And that's how we got these reference ranges also, sir. For Indian women, we've got the ROTEM reference ranges also. For pregnant women in India, as well as we've got the ROTEM ranges for the normal people also. Because we had a hemophilia work also on that, sir.
Thank you very much, ma'am. Very, very fantastic talk. And I believe when you're doing ROTEM in PPH, there is a protocol like, as you have shown your study also, like you do FIB10 A5, the next term A5, and the next term CT, like you do all the...
We don't do INTEM generally. We do EXTEM. EXTEM we run, and at 5 minutes, we take the reading and tell them. And they also have a live screen in the labor room.
And after doing some intervention, then again a test is repeated after 10 minutes.
So that's why I've given the thing, if this is not there, then look for this, this is not there, then look for this. But majority of the cases, it's the FIB10 issue. Because in my hospital, we are not getting fibrinolysis issue, because there our gynecologists are very particular. They give tranexamic acid to every delivery, every cesarean. It's a private hospital, so that's where they do it. But there are a lot of places in India where they're not doing it. So they may get a lot of hypofibrinolysis also.
Thank you, ma'am.
Now there is I think we have I think we have to get up some...
So here we end this session, and next is panel discussion on ITP, steroid resistant ITP.
I think we have to leave and
Yeah.
other party has to come.
May I call upon my esteemed panelists? I believe Dr. Preeti is not there, so Dr. Nair, Dr. Arun, Dr. Deepak. And if I'm missing somebody else, please do come and join. Dr. Sayan, yeah, please. So, respected seniors, dear colleagues, and my dear friends, good afternoon to all of you. At the outset today, I'd like to thank Dr. Subhash Verma, sir, as HOD Medicine and Dean of this institute, ensured that I become part of this PGI family. Sir, I'm deeply indebted to you and will remain always. And I'd also like to thank Professor Pankaj, sir, and Professor Reena, ma'am, who have invited me over here. Pankaj, sir, has been more like a friend, philosopher, and guide. He always has lollipop in one hand and a stick in the other, and I have learned so much, not only medicine but so much things about the life from him, and I hope that I'll keep on learning from you always, sir. With that, I come back to the topic, management of steroid refractory ITP. So much has happened. So lots of things has happened in the last 1 century. So many armaments has been added in the artillery to fight or to attack these ITP things, but nothing much has changed, I must say. The treatments or the methods have all remains relevant even today, barring a few ones whom I have purposefully not highlighted. So a little bit about the ITP. All of us who practice ITP know that it is one of the commonest causes, if not the commonest cause of thrombocytopenia. But the best part is that though all these patients, they remain at high risk of bleeding, we are always afraid of some of the other bleeding manifestation in these patients. About half of the patients, they don't bleed, rather they never bleed. Another thing about ITP is that in general we feel that we know all about the pathology of ITP, but perhaps that is one area which is still not very clear. That is how sometimes I feel that the treatment of refractory ITPs and all, they hang in the middle somewhere. Though lots of work recently has been done for the role of Tregs and other causes, other pathological events in ITP, so is the platelet dysfunction. We have also done a lots of study in this aspect, and these are all coming up. Maybe these will throw newer lights on the pathophysiology of this disease. So a case of acute ITP or severe ITP presents typically with a mucocutaneous bleeding like in this case, and wonderfully responds to the treatment, again like this case responded. But the other part of ITP which usually remains neglected is what we call fatigue. A sizable number of patients, apart from bleeding, they complain of this thing, fatigue, and at times either we ignore it or we feel helpless that we can't do anything about it. Maybe in the time to come we'll do something about this also. Then the investigation part, there are lots of investigations which have been advised by international working groups. They have their own potential utility or uncertain benefits. In our practice, there are few things we do regularly like ANA, manual platelet counts, or APTT kind of things. They have their own benefit, but the most compelling evidence of ITP diagnosis, what I feel, is response to the therapy. Once the therapy part comes, the first line therapy is corticosteroids. All the available guidelines, they leave it open that we can use any of the available corticosteroid, whether prednisolone, methylprednisolone, or dexamethasone, though dexamethasone has been used little more these days. In a recently concluded RCT, what we observed that in an acute ITP case, acute or severe ITP case, if you pulse methylprednisolone to the individual, the initial rise in the platelet is significantly better in comparison to high-dose dexamethasone. Another thing in treatment of acute ITP is use of NTD, immunoglobulin. Of late, neither we are using it nor we are talking about it, but I feel that it is a good drug in the way that we can easily use it on the OPD basis. It is easy to administer, has got good response rate, and also has got a very good safety profile. So with that background, I come to the case which will be discussed today in this panel discussion. So a young lady, housewife, who typically presents with rashes over the body and menorrhagia, has petechia all over the body. We notice patient is also pale. The hemoglobin is on the lower side. The platelet is also low, 16,000. The PBS confirmed that it is thrombocytopenia over there. So likely ITP. We pulse the patient with methylprednisolone 3 days and then put the patient on oral prednisolone. However, there is no response. So the first question to our esteemed panelist, when do you stop steroid in a case of acute ATP or call it steroid refractory case? So we can start from Dr. Arun.
So the literature or the textbook definition of steroid refractory ITP would be when we don't get a response at least by day 28. But what I would want to point out is we don't wait till day 28 to call it or know the trajectory of response to steroids, because the time to response is as early as 5 days to maybe as late as 14 days. But we would generally want to take a cutoff of 28 days. But that is what I want to say, because steroids not only increase the platelet, they act on the endothelium as well. So we don't wait as long as day 28, but we can definitely forecast like the patient is not responding probably to steroid, and maybe there is a case in point to add IVIG or anti-D at that point in an acute severe ITP like this.
Absolutely correct. So we also feel like that only. So in a recent review, we had also taken into account all these things, and we are of consensus amongst ourselves that we can wait up to 14 days of corticosteroids, and if the patient has not responded, it's fair enough to think about the second line therapy in the patient in the cases of ITP. So once the patient is corticosteroid refractory, the first thing is to start tapering the corticosteroid which was being given to the patient. If the patient is having severe manifestation in the form of active bleeding and all, then as Dr. Arun said, we have the option of giving IVIG or NTD immunoglobulins that can be used. But ultimately, we have to use one of the second line agents. The available or the recommended second line agents right now from various guidelines are rituximab, TPO-RA, and splenectomy. These three are the front runners for second line as far as ITP is concerned. So any investigation to be done prior to second line agent, Dr. Deepak?
So in this young lady, I would like to convincingly rule out the common secondary causes of ITP like connective tissue disorders like SLE, then antiphospholipid syndrome, and very unusually PIDs like common variable immunodeficiency disease. If there is any convincing clinical features, I would like to do the second line investigations.
When do you place bone marrow in ITP? Do you do it or you don't do it at all?
So at my center, I do, for all ITP patients, we do bone marrow aspiration biopsy, because it's not possible to have astute pathology department at all centers.
So due to somehow similar reasons, similar reasons, in our clinical practice also in our institute or in my institute, we always get a bone marrow done in any case of ITP. So otherwise, the usual guidelines are a little different, that usually you should try to avoid bone marrow. The routine bone marrow examination in a typical case of ITP is not recommended. But we get it done in that's the truth, due to various reasons, of course, over there. Anything else, like anybody is doing flow cytometry when the patient is refractory, or any role of NGS? Dr. Ashwin, anything like that?
So when we have a steroid refractory ITP and So NGS would mainly come in if you are suspecting some hereditary thrombocytopenia. So if the patient is young and there is some family history of thrombocytopenia is there, and he has not responded to steroids as such, or there are giant platelets or small platelets, some other morphology is there. So in case of hereditary thrombocytopenia, NGS we do consider. As far as flow cytometry and lymphocyte is considered, like sir said, usually lymphocyte subset is if you are suspecting some underlying PID or some other secondary cause to be ruled out. And flow cytometry, I guess, would be part of the bone marrow itself when we are doing the bone marrow study in case of a steroid refractory ITP to rule out other underlying hematological disorders.
Yeah, so very correct. So we are doing lots of flow cytometry in the newly diagnosed ITP cases. How to translate it into the clinical practice, how to correlate it with the treatment of the patients, that is something which I have not been able to find out. I think more and more data need to come before we start guiding after treatment in ITP based on the flow cytometry. I think right now we are far behind that. As far as NGS is concerned, we are not doing it at all. Almost, I think, perhaps apart from few exceptions, I have never got it done. But the data are there, particularly in not just steroid refractory, but patients who are actually multi-refractory kind of things, patients who have got at least 3-4 lines of therapy and has not responded. And this was a beautiful article I came across, where they did this NGS in all these patients, and they have reported that they have picked up the mutations and all which have been suggestive of even connective tissue disorders. So how they have done it and what all are there, it is a complex issue. We'll discuss some other time. But yes, time to come, perhaps. So far we are doing the minimal possible investigation in the case of ITP, but in the coming time it will be difficult. Even those who are handling ITP, they will find it difficult because so many new things are coming up and so many new array of investigations are there. Anyway, so our patients who was refractory to corticosteroid, we plan to give rituximab. I must make it clear that there is as such no specific group of patients who will benefit from rituximab, TPO-RA or splenectomy. These are all depending upon the stage of the disease and more so the discussion between patient and the physician treating. And depending upon who wants oral only, who wants a fixed drug kind of things, fixed duration kind of therapy, and those who are okay with the best possible treatment, even if it is a surgery. So depending upon all these things, usually a decision is taken that which second line will be appropriate for a given patient. In our case, in this case, we decided after consultation with patient that we'll go ahead with rituximab. So we gave patient 375 mg per meter square of a standard dose rituximab, and at the same time we started tapering the prednisolone. However, there's as such a good response and we are happy. So when do we use rituximab in ITP patients? Your own experience and all, Dr. Sayan.
Sometimes difficult decision which type of second line therapy to be started, but for rituximab, female sex, female gender and age below 50 or 40, those are in clinical studies as we find that they benefit the most. Relevance of ANA, yes, in SLE and other connective tissue disorders, rituximab works better. But as such, currently the generic TPO agonists are available. So if patient is willing for a maintenance therapy or long-term therapy, the response rates are better with the TPO agonist compared to the rituximab. Around 60% of 80% response rate with the TPO agonist compared to around 60%. And also the duration of response is shorter in the rituximab group. Around median duration of response is 12 to 15 months, and most of the patients recurs within the 2 years. Only 10 to 20% of patients around, they maintain the response up to 5 years.
So very good comparative data, rituximab versus TPO-RA you have placed. But there are various other things also to be seen. You see, rituximab is a fixed duration kind of things. In a month time, the treatment is over, while TPO-RA is a never-ending kind of things. Even if there are 15-20% patients who have long-lasting remission in rituximab, it will be difficult to get 20% long-lasting remission without drug with TPO-RA. So there are various things to be seen. And last but not the least, now, last few months we are lucky to get generic Eltomopag, with us, or even last couple of years we are getting generic romiplastim, which is very nice. Before that, it was nightmare to prescribe a patient TPORA. It was very difficult. Means financial toxicity was perhaps
Yes.
beyond doubt a major limiting factor. So yeah, I agree with you. So we have been using rituximab quite a lot in our center, and we recently analyzed our data also, how the patient has been doing. So the overall response after the end of a month has been around 60%, which is fair enough. And if you talk about 5 years response rate, how many patients maintain the response at the end of 5 years, it was close to 20%. So that was also not bad. Major issue is sometimes infusion-related reaction, which has to be taken care of. As far as those various factors we are talking about, and we also talk that usually it is good for female or it is good for younger and all. When we did a univariate and multivariate analysis, the only thing where we found that there was a statistically significant value was ANA positivity. All those patients who were ANA positive, their response rate and their long-lasting remission or sustained remission rate was higher in comparison to the others who were ANA negative. Rest of the factors did not matter much. Maybe our sample size was lesser or what, but the most important thing was ANA positivity. Rest all didn't matter much. Anyway, so as it happens, patient remained all right for almost 6 months, and patient was happy. However, happy did not last long, and patient had recurrent symptoms. So what next? This patient was already received corticosteroid. What next would you like to give? Coming back to Dr. Arun.
Yes, this patient is a candidate for a TPORA now. This is almost persistent ITP, 2 lines of therapy. Now, this is a candidate for a TPORA. And among, especially once the financial toxicity part is taken into consideration, and this is an academic discussion, and evidence basis, definitely TPORA I would rate above other drugs. So I would definitely add a TPORA. Between the two, I think it's more of a patient comfort, whether they want a weekly shot or take a pill daily on empty stomach, and how compliant they can be with that. That would decide whether I choose between an L-Trombopag or a Romiplastim.
Any issue, any difficulty, any adverse events you notice which is hindering, which is a hindrance in using TPORA?
So when you read the phase 3 and phase 2 data, trial data, there is some report, I would say 10%, 20 to 15% odd would have transaminitis, and maybe I would say 3 to 5% thrombosis, and definitely because it stimulates marrow reticulin, so there is some reticulin deposition, but there is enough data now to say that the reticulin fibrosis is more of a theoretical possibility. It doesn't really affect the outcomes. Thrombosis, it's very difficult to shaft out between the thrombotic milieu in ITP versus whether it is a TPORA promoted thrombosis which we encounter. But in routine practice, at least in my practice, the 3 years of PGI and then a year now, we haven't come across any case of thrombose, even transaminitis to the point of stopping L-Trombopag. With aplastics, the doses are different, so that is a different point. But I think with L-Trombopag in ITP, we don't chase bilirubin because there is always a problem with pre-analytical variables. Sometimes it's difficult to differentiate between bilirubin estimation when you have a patient taking L-Trombopag.
I agree. Very well said. So we have a TFR expert amongst us, Dr. Goni. So Dr. Goni, have you tried TFR even in ITP who are on L-Trombopag?
No, I have not yet tried. No, I have not done like that.
Okay. Any one of you would like to talk about treatment-free remission, stopping L-Trombopag once patient has been there on L-Trombopag for years?
Yes, at least I have one or two patients, I would say, who have agreed for a TFR, but it's too early data to give you a long-term outcome. So generally we are slow. There are various protocols to taper off L-Trombopag, but generally we start thinking about it when somebody has been on a year at least of L-Trombopag, has hit the peak levels, and then we go slow, maybe taper it and stop it over a period of 6 to 8 weeks, and then definitely monitor the patient, and then put them back on the same drug at the same dose when they, so success rate, at least in literature, is variable. 20 to 50% is what I've read with L-Trombopag, but there are multiple centers, so a lot of biases.
So I have experienced 2 patients of who are receiving romiplastim during my tenure in PGI only, who responded and are maintaining their response without any TPO.
Great. Very nice to hear all of you. So we have been using L-Trombopag at our center for almost a decade now, and we analyzed our data recently. So all kinds of patients responded to L-Trombopag, whether with a spleen or without a spleen, post refractory to rituximab or whatever, the overall response rate was very nice. 81% patient in our study, they had responded to eltomopag, which was very nice. And the side effects were all manageable. Anemia in many patients, anemia as such, though we know that it increases chances of iron deficiency anemia, but still it is manageable. Transaminitis is also not much problematic, as Dr. Arun correctly said, but thrombosis has been there. We also lost one patient to thrombosis who was multi-refractory. I can name at least 5 different drugs which we used in that patient, and patient did not respond to that, including romiplostim, which we used on her. She responded to eltomopag, and with a WBC count of, with a platelet counts of 230,000, she developed ICH, and then CT angiography proved that it is a case of CVT. And most likely one of the commonest causes which I'll attribute in this case is drug, likely. So it's a problem, no doubt. But overall, it is a very safe drug, well utilized, and we are using it quite a lot. A very effective drug. So the patient, we start usually dose of 50 milligram eltomopag daily, and then we either increase or decrease depending upon the response of the patients. But our patients, to the bad luck, this case at least didn't respond to eltomopag. So do you shift from one TPO-RA to another, particularly when the patient was refractory? You know that the patient has not responded to one TPO-RA. So Dr. Deepak.
So I would not like to shift from one TPO agonist to the another, because I personally do not have any good experience with romiplostim in ITP. So rather than shifting to another TPO agonist, I would like to shift to some other second or third line agent.
I agree with you. Any one of the panelists who has done something like this before?
So sometimes changing TPO may do better. I have seen one case in PGI who was refractory to 5 lines of therapy, underwent splenectomy, received rituximab, MMF, azathioprine, all these things. Patient ultimately responded to combination of romiplostim and eltomopag. He is maintaining around 30,000 of platelet. He used to maintain thousands to 2,000s and had ICH. So he is maintaining with the, this is only one case which I have seen, but romiplostim and eltomopag, they act at different sites of the TPO receptor. So this is the logic or the scientific thing which can be used to as a evidence or logic to shift one TPO to another TPO.
Yeah, I couldn't agree more with Dr. Sayan that maybe because of the different underlying mechanism of action,
yes,
there is a chance that patient will be benefited by use of another TPO-RA. Sometime back I was also thinking like Dr. Deepak only. We both are almost, I think, same platform. But I also reviewed these things, and we noticed that people have said that it's better to see whether patient responds or not to another TPO-RA before we shift to any other ITP agents, because you know other agents, they are not just only having lesser chances of showing response, the response rates are very less, but their side effects are also much higher. So it's worthwhile trying another TPO-RA, and that is exactly what we did in this case. So we put the patient on 250 microgram subcutaneously weekly. Usually that is the dose we start with, because that's the vial we get. It may come out to be 3 microgram per kg, or may come up to 6 microgram per kg, but we start with that only, and then we titrate depending upon the dose. And there are various things we have noticed, particularly a unique thing we have noticed is platelet peak. So now, Dr. Ashwin, your experience regarding using romiplostim.
So romiplostim also we have used in patients with ITP. So like Arun sir said initially, the decision to use romiplostim or eltomopag is basically patient-based. You know, there is no real data to show which one is superior as such. If the patient is comfortable in taking subcutaneous injections, then definitely romi can be done. Or if the patient is more comfortable taking oral tablets with that fasting, you know, to be really, you know, they need to take care about the fasting aspect, then eltomopag is the preferred one. So even with romiplostim, the experience is good only as such, and I feel the adverse effects of transaminatis and all is is much lower. Like I've never seen, an LFT really bothering me in patients who are on romiplastin. Whereas in Eltrobag, you may have to, the patient may definitely ask you why this is happening, and you may have to answer that. As far as thrombosis and fibrosis, personally, I don't have any experience of any patient on Romi developing it. On Eltrobag, I had one patient who developed pulmonary thromboembolism, but whether that was due to, like Sir said, because of ITP per se, being a thrombotic or whether it was because of Eltrobag, it's difficult to differentiate.
Great. So I fully agree with you. The unique problem of platelet peak phenomena, what I have noticed that once I start the patient on romiplastin, 2 days, 3 days times, one day I find that platelet count is 13 lakhs, 14 lakhs. It is very scary at times. And you stop, obviously you stop, that you will not give any more romiplastin, and by day 8, day 9, if you repeat it, you will again find it is back to where it was, so back to square one. Again back to 5,000, 10,000, 15,000 kind of things. So that is something which is very unique to it, and usually it tends to settle down as you use it more and more in the same patient. I have not seen that kind of things after 8 weeks or 10 weeks or 16 weeks of use. I've used for last 4-5 years, I've been using their patients who have been there for good about 3-4 years now, regularly taking the medicine, albeit now at a much lower dose, something like 250 microgram once in a month kind of things. And they are maintaining very good platelet counts, no adverse effects. As Dr. Ashwin said, we hardly seen any kind of adverse effects with that. Very safe relatively.
So sorry, if I may just say, like, my patient on Eltrobag who developed pulmonary thromboembolism, actually his count, it was a female patient, her count was 1 lakh on one day, next day it became 5 lakh, then it became 13 lakh. Yeah. And she developed the pulmonary thromboembolism or the symptoms of pulmonary thromboembolism when it became 13 lakh. Great. So in that patient I stopped the TPO, and within 3 days she came back to 9,000. So I think even it is there even with Eltrobag also, maybe we don't see it that commonly.
True.
And I just add a point to that. So because when that happens and when you stop the TPO, what happens is you cannot adequately anticoagulate that patient. Absolutely. So rather we should not be stopping the TPO. We should be building up the platelet to a level where you can adequately anticoagulate the patient.
Absolutely.
And regarding the platelet peak phenomena also, there is this the initial apoptotic block there is an apoptotic break in ITP. When you use romiplastin, that break is immediately released. So that is why there is a lot of MECs maturing and platelets coming into circulation. So if you overreact and reduce or stop, then we are again back in square root 1.
Very apt explanation, Dr. Arun. So we have not only ITP is the disease where we have used Romi, but we have used it in various other conditions also, including stem cell transplant, aplasticemia, various things, and with varied results, and good results rather, I'll say. I'll not discuss in detail. So last but not the least, as far as frontline ITP treatment is concerned, our patient responded very well, so we stopped there only in this case. But splenectomy is another thing which is to be considered. If patient is not responding to corticosteroids, though again after discussion with the patient, and preferably to be avoided in first 1 year, what is said. So any one of you have ever tried to consider splenectomy as one of the options? Dr. Sain.
So as TPO agonists are now available, generic ones are available now, and there is rituximab and other immunosuppressive therapies are also there in our hand. So I place splenectomy later in the ladder, and I will try with the this oral therapies or injectables one before trying splenectomy. And I will wait for at least 1 year, whether if it is possible to get a response or get a fair chance of platelet count which will maintain the hemostasis, then probably I will not prefer for splenectomy. It is a major surgery, and most of the patients also, they do not will for splenectomy.
I couldn't agree more with you that this is an invasive process. Though few things are very clear about splenectomy, that we should not do it in first 1 year. Then it is to be done by laparoscopic method as much as possible, and vaccination is a must for this. About this use of all these drugs and all, since TPO has come, so we will not use it. I must tell you that as far as I know, 85 crore people in our country are sustaining because of 5 kgs free atas. So talking about TPO RA for 1 year is because we are staying perhaps too much into Chandigarh, Delhi and Bombay. There are enough number of people who are candidate for splenectomy and not TPO RA. But anyway, so they perhaps don't reach us. That is also a correct thing. So we recently analyzed our data of splenectomy in our center. We do every year few patients, they do undergo the splenectomy at our centers, and even patients were there who failed on TPO-RA or rituximab kind of things. And at the end of 1 month, very good response rate, around 90% of patients showed response, which is by far the best in any of the drugs. And at 5 years post-therapy also, almost half of the patients were still maintaining their response rate. So response at 5 years was also around 50%, so it was good. OPSI, perhaps earlier it was much more, but now it is less because of availability of good vaccines. At the same time, we have much more access to antibiotics now. So those are things which is important. We can go ahead with splenectomy also sometimes. Before I finish, I think one of the drugs which I usually use in corticosteroid refractory case is azathioprine. I don't know how many of you use it, but it is in use, and even in last ASH guidelines of 2019, Dr. Neunert and company, they did mention that a patient who is pregnant and all, and if you don't have any other option, you can use azathioprine as a drug which is safe in pregnancy as well as lactation. So we have been using it, albeit the response rate is much lesser. At the end of 3 years, around 38% was there in our analysis, and it will be almost like same, 30-40% patients finally respond, but you have to give for at least around 90 days before you decide whether it is acting or not acting. And very mild side effects. Relatively, out of the second line therapies, I think it has got very less adverse events, so not much of issue. There are various other things also which are available. Fostamatinib is one such drug which must be mentioned. I didn't discuss in detail because I have absolutely no personal experience, and perhaps many of you also would not have used it. But when you are talking about TPO-RA, then it is worth mentioned that patients who have thromboembolic phenomena already or are at a high risk to develop any thromboembolic phenomena, it is better, the best drug right now, which is being told now with the data and all are coming, perhaps the best drug will be fostamatinib. Once we get access to that, perhaps that will be a very good thing. Dapsone, our beloved Dapsone, we have been using quite a lot. Danazol, perhaps in PG I have used in the highest number of patients, and so on. Various drugs. I have used vincristine also in patients. I have used cyclophosphamide also in patients. So all of them can be used. We have so many options, but perhaps as the guidelines have correctly said, those three are the best ones which we should use. So once you get the refractory ITP, you can keep on giving a trial of first-line agents, particularly those IVIG and NTD, depending upon severity of the condition, and then you have to go for combination chemotherapy or some neo drugs or trial kind of things, or even alemtuzumab. People are talking about that. But the best, what I learned at PGI is do observation. At times, as half of the patients never bleed, better to go for observation. I think that nothing can beat observation in ITP. There are many unmet needs. We can discuss sometime later about these unmet needs in ITP, like cure is a distant possibility, early detection, diagnosis, what are the importance of that, and so on. So with that, I thank all my panelists, and I rest my case. Thank you very much. Thank you. Yeah, so excellent question. So because it is an excellent question, so answer of this is not known, and there is not enough data to support it. So what I do in my practice is that I know that this is just transient phenomena. So usually I don't think about stopping the drug. Rather I start daily monitoring of platelets kinds of things. And usually what I have noticed that within few days, not even a week, within few days it starts coming down. And once it is less than 4 lakhs, I do restart giving the patients. At times maybe at lower dose, half of the dose, but most of the time at the same dose. That is what I do. Thank you. Thanks, sir.
Thank you for the session. Now we have an interesting session on myeloma updates. We have 2 talks and 1 panel discussion in the session. Second talk is sponsored by Janssen Oncology. To chair this session, I would like to call upon stage Dr. Pankaj Malhotra, who is the Professor and Head of Department of Clinical Hematology and Medical Oncology of Pgi-Hem-Onc Chandigarh. He is also the President of Indian Myeloma Academic Group and a member of Board of Directors, International Myeloma Society. He is the recipient of the ICMR Award of Young Indian Scientist to Mayo Clinic, Rochester, USA, and CML Fellowship, Oregon, Health and Science University, Portland, USA. He has had 553 research publications in peer-reviewed journals and has authored 22 book chapters. And we have Dr. Vijay Kumar, who is the Professor and Head of Hematology Unit, Department of Pathology, AVBIMS, Dr. Aramil Hospital, New Delhi. His areas of interest are benign hematology, flow cytometry, hemato-oncology, and transplant immunology. He has received the Best Postgraduate Teacher Award in July 23 and has published more than 80 research papers in various national and international peer-reviewed journals. Next we have Dr. Jatin Sarin. He's the Director of Medical Oncology and Hematology, IV Hospital, Mohali. His areas of academic interest are all solid and hematological malignancies and has special interest in myeloma and lymphoma. We have an update regarding the change in dinner venue. It will be held in the PGI Lawns instead from 7:30 p.m.
So good afternoon. We are already, I think, running something like 45 minutes late. And my teacher, Dr. Suparno, was telling how come PGI is running late. We should not. So we have to make up little bit time here in the session or have to miss the tea session. So for starting with the myeloma update, we have our first talk on frontline management of high-risk multiple myeloma, and it is none other than by Dr. Chandramouli Nagarajan, who is, MD from PGI. Right now, he is in Singapore General Hospital after spending time in UK, and for the last many years, he is in Singapore General Hospital and has many myeloma-related projects and a very dear friend of mine. So, Molly, all yours.
Thank you, sir. Very good afternoon to everyone, and thank you to Dr. Pankaj sir and the whole organizing committee for giving me this opportunity to be able to share my thoughts on high-risk myeloma today. It indeed is a pleasure and honor to be able to speak to my teachers, my colleagues, and many of you have been my inspiration. Just a slide on disclosure, but essentially to say all the funding goes to the institution. I have no conflict whatsoever to any company. As a hematology group, I don't think you need me to tell you that the survival of myeloma over the last 30 years has really doubled from what it was back in 1990s at 4 years median overall survival to about 8 years currently. But as seen on the curve on the right, the high-risk myeloma patient's survival still remains where myeloma survival was about 30 years ago. So before we venture into the treatment options for myeloma, I would like to cover what do we mean by high risk. The table here, which is from a recent publication, shows the list of panel markers that we currently use for defining high-risk myeloma, predominantly based on bead-selected FISH probes of plasma cells from bone marrow, either using CD138 or CD38. And we have a panel of translocations, and more recently copy number variations, including 1Q21, either amplification or gain. But there have been several variations of this, and in myeloma we do have the complexity of clonal and subclonal heterogeneity that emerges with more and more treatment, as well as spatial heterogeneity, which adds another layer of complexity. But more importantly, this only is scratching the surface, and the panel of mutations are ever expanding as we venture into the era of next generation sequencing, with mechanisms that cover anything from the tumor cell-mediated resistance mechanisms to the microenvironment. And all this probably is just literally scratching the surface, as we don't have good investigations into the microenvironment and the T cells within the microenvironment of myeloma patients. So this is Brian Walker and colleagues' presentation from Arkansas essentially showing that a biallelic mutation of TP53 carries a much worse prognosis than the conventional definition of 17p deletion. And as I mentioned, role of T cells in microenvironment is probably understated. But as clinicians, we also know that there are a whole panel of clinical factors that defines high risk in our patients. Many of these fall into so-called what we call as functional high risk. Initially, patients do tend to seem to respond to whatever agents we give them, but subsequently have a very rapid relapse, and that carries a very poor prognosis as well. The curve here essentially shows circulating plasma cells at the time of diagnosis of myeloma itself can alone show a very different survival for patients. This is our own data essentially showing that even in patients who have been given a similar kind of treatment, patients who do not achieve a very good response. So this is more of a dynamic definition of high-risk myeloma. So patients who don't achieve a CR or who only achieve a CR or a VGPR versus patients who achieve only a PR have a very different survival. This is similar data, but this time from European groups, showing that even in a high-risk myeloma patient population, patients who relapse within the first few months after their induction therapy have a very different survival to patients who remain in a CR. But perhaps this is a much more conventional definition in terms of how people respond. But there is more and more talk on how measurable residual disease or minimal residual disease, where it stands. And this is just the pooled data from the Spanish myeloma group, showing that CR is important. Patients who attain a CR with first-line therapy do have a different survival compared to patients who don't achieve a CR. But perhaps minimal residual disease makes all that difference. So essentially the curves that you saw before have been completely replaced among the CR patients, where patients have MRD negative CR. They are the ones in the blue solid curve on the top. And the rest of them, even if they are in CR, if they are MRD positive, their survival is as close to a patient who only has a PR. Now, the question then arises, so is MRD, measurable residual disease negativity, is it important in high-risk myeloma? This is a figure that I took from the meta-analysis that sees negativity, is it important in high-risk myeloma? This is a figure that I took from the meta-analysis that was published by Munshi et al. As a usefulness of MRD in general, but this figure is from the supplementary appendix, which shows us survival is not as good as a patient with a standard risk FISH. So the first question that comes to us, so we know myeloma treatment happens in phases. We have an induction phase followed by a consolidation phase followed by maintenance phase. So what is probably the best induction that we can give to a high-risk myeloma patient? These are survival curves that I've taken from the IFM 2009 study. The top left curve shows the PFS for the all-comer trial population, clearly showing that patients who achieve MRD negativity do better than those who don't. The curve on the top right shows the PFS curves separated by transplant, clearly stating that all patients who have received transplant or who haven't received transplant but have managed to achieve an MRD negativity state, they do better than patients who even receive a transplant but remain MRD positive. The curve on the bottom left is the same curve split now by the cytogenetic risk. Once again, MRD negative patients, irrespective of whatever treatment they received, they seem to be doing better than patients who don't achieve the MRD negativity. And the same curve on MRD, this time for overall survival on the bottom right. This again is a same IFM 2009 study from the supplementary appendix showing that when they did a landmark analysis from the point of maintenance, start of maintenance, patients who are MRD negative, irrespective of whether they had standard risk at start or high risk, they seem to be surviving as well. So suggesting that perhaps if we manage to get a high-risk myeloma patient with the help of our induction therapy just before they get into the maintenance phase, if we can get them to an MRD negative state, we can give them a survival that is as close as possible to a standard risk myeloma patient. Now, we have talked about frontline with triplet, typically VRD, and now that bortezomib, Velcade, lenalidomide are all generic, that is probably feasible, but can we upgrade that response using a second-generation proteasome inhibitor? So this is data from the Forte study. For interest of time, I have not included the construct of the study, but essentially it is carfilzomib combined with cyclophosphamide or lenalidomide. In this, both arms, there was transplant, and the third arm was KRD alone without transplant, 12 cycles. And as you can see, wherever we added this point, that this study, as recent as it is, still manages to convince us the utility of a frontline autologous transplant, in that even though the achievement of MRD negativity after induction and consolidation is somewhat similar between the KRD and transplant arm compared to KRD12. Once we talk about sustained MRD negativity, i.e. patients remaining in minimal residual negativity status 1 year after their transplant, you can see the number of patients that have dropped off in the KRD12 arm. So even if you were to give a second-generation proteasome inhibitor and lenalidomide in the front line for a high-risk myeloma patient, they might get to an MRD negative state, but without a transplant, you're going to be hard-pressed to keep them in an MRD negative state if you don't use transplant. Now, what about adding a CD38 antibody to frontline treatment on top of the triplet treatment? So I've shown frontline VRD, frontline KRD, now adding on a CD38, and I'll first share adding daratumumab and then followed by data for isatuximab. So this is essentially showing that MRD negativity is achievable, even higher proportion of patients when we use CD38 antibodies, including even minimal residual disease negativity. And this is essentially showing that this does transpire into PFS. But I have a few problems with the study design. And as you can see here, the PFS separation of curves does not happen till the second year. And that is because the study had a few problems in terms of keeping patients with maintenance treatment, particularly in the triplet arm. So we'll have to wait for the Perseus study's results that comes out probably later on this year or early next year, which is the phase 3 study using Dara-VRD. Now, this is a very interesting study and particularly tries to address the question of the utility of a quadruplet regimen in specifically high-risk myeloma population. The German myeloma group did this concept study, which used isatuximab and used a second-generation proteasome inhibitor in carfilzomib together with Lendex. And clearly, once again, the high-risk myeloma definitions were very clear here, as well as the primary objective was MRD negativity, not just 3R or stringent CR as it was in the prior studies. And once again, this shows that close to three-fourths of patients, or nearly 2/3 of patients, did manage to achieve an MRD negativity, and this is after induction. But it does come at a cost, and a vast majority of patients do get infectious complications when you use quadruplet regimens with transplant, and we have to be careful about that. The next discussion is on consolidation. So what is best for consolidation? We can discuss all day long about the usefulness of tandem ASCT, but unfortunately, most of the trials that have investigated tandem transplants have all been in the era where PI and IMiDs were not used for induction. The one study that has been done in this particular group is the Stamina study. As we know, the frontline initial results of this study, which investigated tandem auto versus auto followed by RVD instead of the second auto, and finally autologous transplant and then going straight into maintenance, showed no difference in the initial results. However, the subsequent results were recently presented at ASH meeting last year, which showed that despite no differences in the initial results, patients in particular with the high-risk phenotype, as shown here, who received tandem transplant, did have a better PFS at 5 years compared to the other two arms, stating that still this question of tandem transplant, even in the era where we use PI and IMiDs in the first line, is still open. Now, another interesting, fascinating study that has recently come up is the MASTER trial, which essentially is asking the question, so can we take out treatment for myeloma patients and stop treatments in at least a proportion of patients? So the study design is as mentioned here, with 4 cycles of Dara-KRD given in a block, and after every block, patients receive an MRD assessment. And as you can see here, the definition of this study population has been it's been designed to enrich with high-risk myeloma patients. The definition of high risk in this particular study is mentioned here, so conventional IMWG definition plus 1Q-amp. And though it sounds quite complicated in the slides, I just want you to take two main messages from this slide. One, as you go from all-comer population to two high-risk chromosomal abnormalities, as patients get more and more blocks of DARA-KRD, their MRD negativity increases. And second, patients with two high-risk chromosomal abnormalities, though they may be able to get them into a MRD negative state with further cycles of DARA-KRD, they don't get into an MRD negative state in a sustained fashion. And this was reflected when we get the PFS curves for this study, as well as OS. And this was probably the first study where it showed that because it is given in a fashion where MRD positive patients continued treatment and MRD negative patients did not, the survival of these two population of patients came close such that there was no difference, but still OS did show a difference, although there was not statistically significant. I'll skip the slides and then move swiftly into the transplant ineligible patient group. The initial trials that have been used, which probably don't use apart from in very few frail patients using doublets these days. We can talk about VRD in the SWOG trial. It was obviously the first trial that showed an overall survival benefit, but really SWOG trial is not a trial for transplant ineligible frail patients. As you can see, the median age of this trial, of patients in this trial was 64 years, and nowadays we do transplants up to the age of 70 or 75, so this is not really reflective of a non-transplant eligible population. The next study is the DARA-VMP Alcyone study, which showed clearly a superiority of the quadruplet even in a transplant ineligible population. But there is a pooled analysis of DARA-VMP and MAIA study that has been published. Outside of this, I couldn't find any data and the usefulness of high-risk myeloma patients in terms of DARA-VMP. So probably the most important data that we have for high-risk myeloma in a transplant-ineligible population comes from the MAIA study. We all know the trial consults straightforward comparison of DRD versus RD in this group of patients, and the vast majority of patients were truly transplant-ineligible in this study, with more than 30% of patients having an age of more than 70. Clearly, the median PFS of 60 months or 5 years in a transplant-ineligible group was not seen ever with any other frontline treatment, as well as the most recent final analysis which showed that the 48-month 4-year PFS is almost comparable to a standard risk myeloma patients given frontline transplant. So one message here is to say that by reserving these novel agents, particularly CD38 antibodies, into the second, third, and fourth line setting, we are probably not doing the best option for our patients, but equally we need to balance the cost in terms of giving these agents day in and day out forever.
So, Molly, can you just
So
your final
just a couple of slides on what we have done, and then before I conclude. So this is our own study, which is essentially mirroring the Forte KCD arm, and we have had pretty good results in terms of achieving deep responses, and this is an exclusive high-risk myeloma patient trial. And the PFS is almost 4 years in this trial population. Finally, this is our elderly trial, which we've recently completed, and hopefully, with a bit of luck, we might be able to present this at ASH meeting later this year. And this is our collaboration with the International Myeloma Foundation. Starting from 001, we are now on to 010. I'll probably skip that and then conclude by saying that high-risk myeloma is a heterogeneous disease, and it is important to identify not just genomic, but also clinical and functional high-risk myeloma population. At the very least, I would suggest we should use a PI and an IMID population and consolidate them with transplant as much as possible. We are not sure of what is the best therapy of high-risk myeloma in a truly transplant-ineligible population, though daratumumab combined with lenalidomide does seem to have some role in those patients. We should consider tandem transplant, particularly in 17P patients. And perhaps the maintenance question is still open as to using a combination of either a CD38-directed antibody versus proteasome inhibitor. And we should probably aim for the deepest remission possible and to aim to keep them there in these high-risk myeloma patients. Clinical trials are priceless for these patients, using novel agents especially. And newer novel agents have the potential to change the landscape of this patient group. But not to forget the sight of toxicities which are so crucial to prevent in our patient group. So with that, I'd like to conclude and say thank you for your kind attention.
Yeah, thanks a lot, Dr. Chandramouli. It was really a nice talk, and I think we can skip at least this, comment and question. We can have it later because we are already, there is a paucity of time. So, we would like to go for the second really interesting talk regarding the management of relapsed multiple myeloma in 2024 by Dr. Hari Menon. And sir is a professor and head in the Department of Medical Oncology, St. John's Medical College and Hospital at St. John's National Academy of Health Sciences, Bangalore. His academic interests include myeloid neoplasms, aggressive lymphomas, myeloma, cellular therapy, clinical protocol development. Sir, Dr. Hari Menon, please.
Thank you, and thank you for the organizers, Dr. Pankaj and the entire PGI team to have me here. It's been a pleasure, a wonderful conference. And to take on from where my colleague Dr. Chandramouli has reflected on the various aspects of treatment of newly diagnosed multiple myeloma, I switch gears to the next aspect of the management of relapsed multiple myeloma. So when we talk about the natural history of myeloma, as it was quite alluded to, we do have excellent responses to the first-line therapy, and the success of myeloma treatment has been enabled to maintain the therapy for a significant period of time, and we know that the responses have been ever improving, and we are looking at median survival of close to 7 years, 7 to 10 years these days, depending upon which risk group we are dealing with. But we also recognize that once myeloma relapses, there is going to be progressive decline in the responses, and the duration of responses that we achieve are progressively getting lower and lower. So, and once to a point where we have a refractory state where we do not get any durable responses. So challenge of myeloma has always been that it's an extraordinarily heterogeneous disease, and there's an acquisition of mutations as we go along the course of myeloma as it progresses, and the reason why they go into relapses and refractory state is because of acquisition of new mutations. No two patients may have the same exact genetic makeup, and this gives an opportunity for us to exercise various treatment options after understanding what is the mutation profile or the cytogenetic abnormalities that are prevailing in these patients. So we also understand that the culprit is the development of these mutations, and as we go down from treatment 0, which is the new treatment, to treatment 1, treatment 2, treatment 3, we can see that there is a progressive decline in the responses, and that is primarily because of several 5 unique clones which are present at the diagnosis, and variable chemotherapy responses, and minor drug-resistant clones that may be lethal. And the figure on the right side is an elegant study where they sequentially looked at patients right from the time of one patient right from the time of diagnosis to the multiple relapses, and you can see the acquisition of resistant mutations, which allows for progression of the disease and lesser responses. But having said that, we have been significantly successful in tackling this problem of relapses over a period of time, and this graph clearly demonstrates, along with the success that we have achieved in managing relapsed refractory myeloma, in that we have been getting newer and newer modalities of treatment and newer targets that we can exploit for benefit in treatment of myeloma. And these include improvement in the existing targets, and also the identification of using monoclonal antibodies to target receptors, especially the BCMA and some of the newer receptors that have come in, to be able to exploit them for therapeutic benefit, and also understanding some of the pathways that are present in the myeloma cell, especially some of them that are present present in a few of the myeloma cells, which includes translocation 1114, which is associated with excessive BCL2 expression, wherein drugs such as venetoclax can actually have a distinct impact, which I will allude to in some of my subsequent slides. So relapse is almost inevitable, and refractoriness is an intrinsic feature of myeloma, and therefore, how do we strategize for optimum outcomes in these patients? And that is a challenge of approaching relapse refractory myeloma. So the questions that we need to ask when we are addressing a relapse refractory myeloma: do I really need to treat this patient? That's the first question that comes. And does the patient have new high-risk features that have developed at the time of relapse? And what drugs have been used so far, and responses to the previous treatment, and how well has the patient, which includes a performance status, what is the marrow reserve of the patient, and what are the patient's goals and preferences also, which has to be taken into consideration. So how do we select treatment? And that depends upon the prior drug exposure, the toxicities of prior drug, which helps us decide specific drugs that can be used for that particular patient. And then comes the age, frailty, the patient's preference, goals, etc., which helps to decide the dose and the schedule of the drugs. And then also we look at when you're dealing with very high risk features versus the standard risk features, it helps us decide what is the overall treatment approach, the duration of treatment that we need to look in. So the general principles of treating relapsed refractory myeloma is that the duration of initial response is defined by the biology of the disease. So if a patient has relapsed very shortly after a primary treatment, we would expect that the biology of the disease is worse, and they're likely to do poorly with any subsequent treatment. And it's always useful to understand that using more drugs, that is, using a triplet, is preferred over a doublet regimen. And consideration for performance status, age, and comorbidities are of extreme importance for us to be able to balance out the treatment that we can offer these patients without too much toxicity. Because if you can't implement a treatment, then we can't expect results for that particular patient. And we also take into account prior toxicities that the patient might have had, including neuropathy and various other side to antecedent therapy that the patient might have had, and you treat to achieve a maximum response like how you would in an induction therapy for a newly diagnosed multiple myeloma. So what is choosing an appropriate salvage over here? And you're taking into account the pace of the disease and the number of relapses that the patient has had. And I try to categorize this into three scenarios. One is treating an indolent, slow-growing myeloma. I mean, I put it in inverted commas because we can never say that a myeloma is indolent, but you have a fair idea based on what is the time to relapse from a primary treatment for the patient. And when we are dealing with that kind of a situation, when we are sort of categorizing them as indolent and slow-growing, then we look at whether we want to use an IMiD-based salvage, or whether we want to use a proteasome inhibitor-based salvage, or whether the patient may be eligible for a second transplant. And of course, an IMiD-based salvage is usually a treatment that when initial treatment with bortezomib has been used, and many may consider single agent with or without dexamethasone, but that's again something which we do not allude to because, as I said, using a triplet regimen is always better. And therefore, the emphasis in these situations is more towards using a next generation immunomodulatory drug or a next generation proteasome inhibitor. Then you have the next scenario where a patient has had a very good response and the patient has relapsed the disease. And again, our emphasis is towards using the next generation rather than using the same kind of drugs that we used before, because intuitively one would think that they might be having resistance to these drugs, as against the previous scenario when it is sort of something like a slow relapse. So the emphasis over here would be towards using a monoclonal antibody to be added to the regimen, whichever you use, whichever is a backbone, whether it is a proteasome inhibitor or whether it is IMiD. Then we have the very aggressive myelomas with rapid multiple relapses which are occurring, which we come across, which we call as triple refractory diseases, which we know have got poor outcomes, and we need to be more aggressive. And sometimes we, depending upon the resources that we have, we tend to use, earlier we used to use very aggressive chemotherapy-based salvages like the DCEP and DTPase regimens. And also, we also used to explore the possibility of an allotransplant in these patients after trying to put them into some sort of a decent remission. But again, with the development of science and understanding the biology of the disease and using targeted therapy, now we are moving more towards, in these subset of patients, towards using a targeted therapy, which the most popular being a BCMA targeted therapy. So the rational approach to first relapse and later is always based on what we have in our, what is available for us, what the patient has responded to, and the profile of the patient, the toxicities of the patient, and how well he can withstand the drug that we can. So most of the time, as I said, we would want to use a triplet regimen in these patients. So, so when you have a lenalidomide-based combination, we do have the treatment where with ASPA and the Tourmaline study clearly demonstrated the advantage of using a carfilzomib-based regimen, and all the oral neoproteasome regimen, which is ixazomib in the Tourmaline study, which clearly had distinct improvement in the progression-free survival in these patients. Similarly, the use of a monoclonal antibody in a lenalidomide-based regimen was a POLEX study for patients who have been used, who had relapsed after using bortezomib-based therapy, and this was reflected in the POLEX study, which I will just allude to, and the ELOQUENCE study, where we use elotuzumab in these patients, along with lenalidomide in these patients. Strangely, one should realize that when we use elotuzumab in patients, they need to be used with an IMiD because there is an immunomodulatory effect for IMiDs for the benefit for elotuzumab. So this is the POLEX study, clearly demonstrating a distinct improvement in the progression-free survival when using daratumumab in combination with lenalidomide. So what about the situations in bortezomib-based regimen where we are having, where they have relapsed on an IMiD maintenance like lenalidomide, and these are the situations where we would exercise that combination of monoclonal antibody along with the proteasome inhibitor, and that was most popularized by the CASTOR study, which looked at using daratumumab in combination with proteasome inhibitor, and again, as was true with the POLEX study, almost identical outcomes in these patients, in tremendous improvement in the progression-free survival, which was almost doubling the progression-free survival in these patients. The CANDOR study was, again, using a combination of daratumumab with the next-generation proteasome inhibitor, and that was clearly, again, showed an improvement in the progression-free survival, but there was a crossover design over here, which therefore did not show an improvement in the overall survival in these patients. The ICARIA study is the next generation, or the other anti-CD38 antibody, which is isatuximab in combination with pomalidomide and dexamethasone. And the APOLLO study, again, looked at the use of daratumumab in combination with pomalidomide, and as like the APOLLO study, distinctly, again, showing an impact for the use of daratumumab in these regimens. So the IKEMA study was, again, looking at the combination of isatuximab with the carfilzomib in dexamethasone. And all these studies, and to put it in a nutshell, would say that using a daratumumab-based regimen in combination with a proteasome inhibitor or a next-generation IMiD would probably have an impact in terms of better progression-free survival in these patients. What about switching to a different class of medication, such as selinexor and BCL2 inhibitor? I'll just rush through this because in the interest of time, the selinexor is a XPO1 transport inhibitor, which again showed in combination with dexamethasone and proteasome inhibitor, clearly demonstrated improvement in progression-free survival, but toxicity was a major problem in this situation. And the Bellini study, as I said, clearly used venetoclax in patients, and the benefit was seen in BCL2 overexpression, and that was clearly seen in patients who had 11-14 translocation, and that was improved outcome. And if you do find a 11-14 translocation, then there is a use for tracks in these regimens. So the problem that we have now is to deal with triple refractory diseases. And we know that triple refractory disease extremely poorly with whatever treatment that we have. And it is over here that we have to exercise the option of targeted therapy, which is again, we are using the BCMA targeted therapies over here, which can be either an antibody drug conjugate or a BCMA directed CAR T-cell therapy or a bispecific antibody, naked antibodies. And there are multiple targets that have been up, the most popular of them being the BCMA. I will just go through, I'll just skip these slides in the interest of time. So what do we have as far as antibody drug conjugate is considered? It's a BCMA targeted antibody tagged with a microtubule inhibitor, and it showed, in principle, it showed an excellent response in terms of improving the progression-free survival. But the problem again over here was the intense toxicity, especially almost 80% of them had keratopathy. So, so the BCMA targeted therapy, as far as the CAR T-cell therapy, there have been two main drugs, with idacaptogene and ciltacabtagene, which is there. And these were the two studies which have reached the phase 3 in terms of outcomes for these patients. And idacaptogene was for the first, and the phase 1 study was published in the New England Journal with Nupur and group, and the KARMA study was a phase 2 study, and the KARMA phase 3 study, which clearly demonstrated an improvement in outcomes in these patients in terms of irrespective of what the cytogenetic profile was, what is the time of improvement. And for the first time in this class of patients with a triple refractory, you had excellent outcomes. The CARTITUDE study was a phase 1b/2 study, which again looked at cilta-cel, which is the other BCMA targeted CAR T-cell, and the phase 4 study was
Dr.
recently
Menon,
published.
sir,
Yes.
kindly summarize. Thank you.
Yeah. And the CARTITUDE study was the phase 3 study, which was published recently, clearly demonstrating a significant improvement in these patients who had failed 1 to 3 lines of therapy. So this is the beauty of the CAR T-cell therapies across all high-risk groups, irrespective of what the time of relapses, etc., they tend to still show responses, as is shown in this forest plot. So I have no time for discussing the monoclonal antibodies and the bispecific T-cell engagers. So I will just conclude by saying that the BCMA-targeted therapies, what are the considerations when we want to talk about BCMA-targeted therapy, whether we use a bispecific antibody, it depends upon what is available. Sometimes the patient cannot wait for a CAR T-cell therapy, then it might be useful to use a bispecific T-cell engagers because the effect is essentially the same. So I will conclude by saying that the therapeutic advances have had prolonged survival in multiple myeloma, and the treatment of multiple myeloma requires a long-term strategy. And the key is delivering the best package of treatment at a given stage, optimum combination and sequencing as a key. And switching to regimens with new drug classes offers the best outcomes. And the future will be for developing new individualized approaches for multiple myeloma. And as my colleague said earlier, it might be useful to use the most active drugs upfront in these patients rather than wait for them at the time of relapse. Thank you.
Thank you, Dr. Menon. Well, these were the very difficult subsets to treat myeloma patients. Both the deliberations were quite extensive despite the time constraints. I think we'll be taking the questions in the panel discussion. So I would now like to invite Dr. Aditya Jandial. He is an assistant professor, Department of Medical Oncology at Homi Bhabha Cancer Hospital and Research Center, Mullapur. And his areas of interest are plasma cell dyscrasia, and I think he'll be thrashing out these things about the high risk and relapse myeloma, practical aspects in the Indian settings. The panelists for this session are Dr. Salim Mirza, Dr. Chandramouli.
Salim is not there.
Dr. Hari Menon, and Dr. Gautam Goyal.
And sir, you can ask those questions now directly to the panelists also.
No, I just have a question to mankind more than any specific individual right now. That I feel more like Rip Van Winkle, waking up after some 20 years. So when I went to the UK in 1997 and the reduced intensity transplantations had taken shape, non-myeloablative and reduced intensity. So myeloma transplantation allograft was a no-no before that because there was 40% plus mortality from conditioning. And that time there were 2 studies initiated with tandem autoallo, irrespective of risk group, etc., which we come to know now. And 10 years follow-up study, the European study shows that there is a 30% plateau in the tandem autoallo group. Now, sort of I wake up in 2024 and see that all of you have got together and declare myeloma is an incurable disease. Myeloma will relapse, myeloma will become refractory, but please don't do allograft. I mean, it is a bit like, that India will go to hell, India will go to dumps, but please don't vote for Modi, sort of thing.
You want to say about role of allograft? No, Naveen is there. Naveen, you want to respond to allograft in myeloma?
So is he in that INDIA gang or what?
So I can just, before Naveen can come, the problem with allograft has been, we know that there is an anti-myeloma effect with an allograft, but the challenges have always been with managing the toxicity and the high mortality rates associated with an allotransplant in these patients. Now, with the advent of many of the newer modalities of treatment that have come in, probably we started revisiting myeloma, allograft, but with the newer modalities of treatment, with the highly effective CAR T-cell cellular therapies, I think still the allograft has taken a back seat. It's nothing against doing an allograft, but it's a challenge doing allograft in myeloma.
Yeah, of course, the issue, that's the thing I wanted to come forward, that doing an allograft is one of the most challenging things in medicine. And there are very few allografters alive at the moment who want to do allograft. I would rather keep on giving tablets and injections, and that's not my responsibility at the end of the day. Myeloma is going to relapse, it will become refractory. Once I do an allograft, I take it on my shoulder that I'll cure the patient. Those are few and far right now. You do a CAR, it's all fine, you have a response 90%, but down the line, 3 years, 5 years, almost everyone is going to relapse, and everyone has relapsed. You have seen it in ALL, that you, after doing a CAR, you are going for an allograft because you cannot sustain a remission with the CAR alone. So spending 450,000 one-off therapy, it's not a one-off therapy. Yes, allograft, the Achilles heel of allograft is there has been no funding, no investment, no sponsorship on allograft because it's not a product. And that's the reason it's not developed in the last 15 years since PTCY. All we have to do in allograft, as you said, is to reduce NRM, reduce mortality, and try to reduce relapse one way or the other, because there is no stronger form of cellular therapy than allogenic T-cell or allogenic NK cell therapy. So accept it and then say we can't do it.
Why are you putting me on a spot between two people? Anyways, I agree with both of them. If CAR T-cell makes a difference in the relapsed myeloma, it's because of the T-cells, and there's nothing better than allograft as far as T-cells is concerned. And I agree with Dr. Sripono. If the NRM can be brought down, then certainly there is nothing which can replace allogenic transplantation in some of the hematological malignancies. So basically, you just have to make it less toxic. No, I'm not defensive. No, so like an allograft. So the problem with allograft in myeloma is obviously the toxicity is more because of the patients and the number of lines of therapy that they receive, and they are more elderly in our context, more than 50, 55, or 60. In the acute leukemias, we usually take patients who are slightly less in age. So if the non-relapse mortality can be reduced, and of course it has come down, I don't think I have any doubt in my mind that allogenic transplantation remains the best treatment for some of the hematological malignancies where there is graft versus tumor effect. So, I have no confusion.
So I think that's what Dr. Suparno is trying to say. It is a challenge, and as a hematologist who are doing allograft, they should take it as a challenge how to reduce TRM, and once we know there is a graft versus myeloma effect, at least for triple hit myeloma or for a very high risk myeloma where we know that the median survival is less than a couple of years, there at least we should think. This is what I think the message is trying to carry, that you are not thinking of allograft, and we must think about that. I think now, Dr. Aditya, you can start your panel discussion.
Good evening, everyone. I sincerely thank the organizing team for giving me this opportunity to moderate this panel discussion. And in next 30 minutes or so, I would be asking some amateur questions, and I would sincerely request the myeloma gurus present on dais as well as in the audience to answer them. So to begin with, we have a case scenario, a 58-year-old gentleman from Patiala, Punjab, who presented with low backache and fatigue for 3 months duration. And on evaluation, he was found to have normocytic normochromic anemia with normal serum creatinine and calcium values. There was AG reversal on the biochemical examination, and LDH was normal. MRI showed T1 hypointense lesions in the thoracic and lumbar vertebrae and the L1 vertebral collapse. So SPEP showed M spike, which corresponded to IgG kappa, and on quantification was 2.2. And SFLC showed kappa lambda ratio of 60.1. The bone marrow examination showed 45% plasma cells with translocation 414 on FISH panel. And on the basis of beta-2 microglobulin of 6.2, he was labeled as ISS3 and RISS3, newly diagnosed multiple myeloma. So he was started on BRD induction, and after 8 cycles he achieved stringent CR with MRD negativity on bone marrow flow cytometry, which was done on bone marrow aspirate. And subsequently he underwent the autologous stem cell transplant with MEL200 conditioning, and day 100 assessment showed stringent CR, MRD negative and PET negative. So subsequently he was given bortezomib and len maintenance in view of translocation 414 being present at the baseline, and at 2 years there was biochemical relapse, and at 2.5 years there was clinical relapse with M-band showing 2.5 grams per deciliter. And the bone marrow examination at this point showed 60% plasma cells. So my first question to the panelists is, what strategy do you select while choosing the therapy at the first relapse, and whether you go ahead with the doublet, triplet or quadruplet, and how does the approach changes in old frail patients versus young fit patients? So since Dr. Salim Mirza, he is not here, I would request Dr. Chandramouli, you take up the question.
Okay, thank you. First thing to mention, in the older IFM studies, so we can discuss about the role of 414 to be classified as a high-risk myeloma. But in the older IFM studies, we clearly know that 414 myelomas, which have a very high beta-2 microglobulin, reflect a separate population, and they are truly high risk, and we've illustrated that beautifully in this patient. Second, I think the induction and the treatment that this patient received, I think has worked very well. So, congratulations on achieving MRD negativity even before a transplant for this patient. But as is usual is the case in these high-risk myeloma patients, unfortunately the patient relapses. Now, coming back to your question, I think there is no trial data evidence to suggest the usefulness of a quadruplet therapy at first relapse or any relapse subsequently, as far as I know, unless you classify chemotherapy-based quadruplets. So we'll have to stick with triplets. And given the 414 and the sensitivity associated with it to proteasome inhibitor, I think the first thing I would want to choose is a proteasome inhibitor-based backbone. Now then you think about what can we add to this. So you're already given a patient who is not just exposed to PIs and IMiDs in induction, but they've also received maintenance that is based on both of these agents. So when the patient is relapsing on proteasome inhibitor first line, we'll have to use a second generation proteasome inhibitor and carfilzomib. Now we know the data for Candor as well as IKEMA showing superiority to their respective comparator arms. So I'll choose a carfilzomib based backbone, preferentially using the partner as a CD38 antibody. So either isatuximab or daratumumab would be my first line options for discussion for this patient. In terms of old, frail versus young, fit patients, I think, as we all say, myeloma is a marathon. You don't want a frail patient to be given a very aggressive type of therapy and relatively, shortening their overall survival. But equally, the issue is this is a very high risk myeloma, so you don't want to get into a second line therapy that is very poor on the efficacy side and get into a relapse within 3-6 months and you don't have anything else to use. So I don't think the answer is very clear-cut in terms of what efficacious agent you're going to use, but more, I think, revisit the goals with those patients. What is the aim, be it whether they, place the emphasis on symptom improvement versus actually achieving a relatively good PFS. That kind of argument or discussion with the patient would be what I would be doing.
So that's very well put. So as we look at the frontline treatment of newly diagnosed multiple myeloma patients, so depending upon the eligibility for autologous stem cell transplantation, we either give induction consolidation followed by maintenance in transplant eligible patients, or in transplant ineligible patients we give induction followed by continuous maintenance. But as Dr. Chandramouli said, myeloma is not a sprint, it is a marathon, and actually it is just like a game of chess. We need to anticipate when what is expected in the near future of patients, especially the patients who are high risk, and to anticipate the salvage therapies in such scenarios. So in addition to the conventional alkylators, IMiDs and proteasome inhibitors, in the last couple of decades there have been significant broadening of the multiple myeloma treatment landscape, and we have anti-CD38 monoclonal antibodies, small molecules like selinexor, venetoclax, CELMoDs, and the immune therapies. So it is just like a jigsaw puzzle, and we need to actually take into consideration the patient and the disease-related factors so that we can come up with the best combination that can give the best outcomes for our patients. So we need to understand that with each subsequent line of therapy, there is significant attrition as far as multiple myeloma therapy is concerned. So as Dr. Hari mentioned, that we should keep our best regimen upfront, because we might not be able to use it later in the treatment of relapsed multiple myeloma. And it is important to identify the progression or relapse, and it has been clearly defined in the form of rapid doubling of M spike or increase in M protein by more than 1 gram per deciliter, and increase in urine M protein and involved free light chain levels. So as mentioned, disease, therapy and patient-related factors we take into consideration, and these are important in choosing the combination. So the idea is to involve or include the patient, include the medications with new mechanisms of action. And as of now, since most of the centers are using VRD induction and they have incorporated or adopted the VRD induction, so most of the patients we find when they are either on the LEN maintenance or off LEN for variable time at the time of relapse. And as mentioned, we use combination of daratumumab or isatuximab in combination with Pomdex. And these are the names of the trials which have used these triplet regimens in patients who have received 1 to 3 prior lines of therapies. So the addition of monoclonal antibodies to a backbone of IMiD and DEXA, or the proteasome inhibitor or DEXA, it has clearly shown that it leads to improvement in PFS, and these are the studies which were published till 2016, and these are the recent studies that were highlighted by the previous speakers that have also shown that triplets are superior to doublets in the setting of relapsed refractory multiple myeloma, especially in the setting of patients who have received 1 to 3 prior lines of therapies. And these are the curves for the PFS for the Candor, Apollo and Optimism trial, and you can clearly see that the median PFS is better in patients who have received triplets. And when I looked at like the recent literature on the early relapsed multiple myeloma patients, the one study that came to the limelight recently was the IKEMA, where isatuximab, carfilzomib and dexa actually led to significant, very impressive PFS benefit of close to 36 months as compared to 19 months in the KD arm. And when we look at the results, the outcomes were superior in patients who had 1q21 amplification. So looking at these Candor, Aspire, IKEMA studies, different carfilzomib doses have been used. So my question would be to Dr. Chandramouli regarding, first, many times as a resident or as a fellow, we used to see patients who were on low doses of lenalidomide at the time of progression of relapse. So how do you approach such patients, and whether the similar paradigm is applicable to the patients who are receiving once monthly DARA? And the third subset is like the dose of carfilzomib. Sir.
Sorry, the questions here are different to what you're asking. Can you repeat them?
So the first question is like your approach to the patients who are relapsing while off len versus on low dose len. And second is whether the same approach you follow for the patients who are on monthly daratumumab while choosing the therapy, and what is the dose of carfilzomib that you use?
So first question, lenalidomide, right? So there is a Greek retrospective study that specifically served to address this question. I can send you the reference if you like. So they basically define, so how do you define len refractoriness first? The IMWG definition is on treatment or within 60 days. Second, the particular retrospective study tried to address the different doses of len, as well as generally how and what does pomalidomide add in that particular population. They chose a uniformly POM-DEX treated, doublet treated patients on patients who have received some kind of lenalidomide containing regimen in the immediate prior regime. And what they found is basically this: if patients were receiving len at any dose, whether it is 5, 10, 15 or 25, the POM response was not different. Meaning to say that as long as you're on len, you are len refractory, and your POM-based therapies are not usually going to be solving the problem. Second, though, that they found is when patients are on len on a very long time before the len refractoriness emerges, those patients are much more likely to be salvaged to the POM-based regimen compared to patients who have been on 3 months, 6 months of a len-based regimen and then they progress. So that suggests to me that the biology of disease in those patients are probably different, and the len refractoriness is probably not the main thing or factor in that particular patient. The second question you asked was about daratumumab. I think the argument here is very different. I think the mechanism of action, the way they work is very different. So once patients have been exposed to daratumumab, you've given them a higher induction phase with multiple weekly doses, then followed them to a reduced dose once every couple of weeks and so on. And it doesn't matter. Once you even get them to a once monthly dosage, I think it is unlikely that another CD38 therapy or even intensifying the CD38 that you're currently using is going to be very much useful. Now, the one situation where I might differ and try something, and I've got some personal experience in this, in the study that I showed that we ran, which is my trial, the daratumumab Velcade-Dex in frontline myeloma in elderly patients. I've had a few patients where after initial response, 4-6 months later, when their M-band plateaus, and in a few patients even started to increase, instead of, by that time, they usually go on to a maintenance daratumumab cycles. So I took them off trial because they have progressed, and then tried daratumumab lenalidomide, because there is obviously much more synergy with CD38 antibodies and IMiDs compared to CD38 antibodies and PIs, be it Velcade or carfilzomib. I think the additivity that you see in IKEMA and Candor is more an additive effect, not a synergistic effect. Whereas with CD38 and IMiDs, you have really a synergistic effect. Not just in terms of efficacy, but I see that in toxicity as well. And I was talking about this with Dr. Suparna yesterday. Many of my very elderly patients who are 78, 80s, usually we cannot deliver 25 mg lenalidomide to them. Whereas I've got so many patients now on DARA and LEN in the 78, 80-year-olds who are taking 25 mg len like nobody's business. And intuitively, I think many of the side effects of LEN, like skin and GI and everything, are possibly mediated by NK cell activity, and we know DARA has an anti-NK cell activity. I think what the LEN is inducing in terms of side effects is probably nullified by DARA, and hence they can take, and obviously there is more synergistic effect for their efficacy as well. And your last question was about
carfilzomib dose.
That is a big question, isn't it? So I don't know what exactly is the right dose when, so we have different combinations. So when you're using carfilzomib alone, what I practice personally is, as much as possible, I don't bring down to once weekly, especially in a high-risk myeloma patient. So I use 56 mg per meter squared twice a week, or as long as possible. When the patient is tired, when I'm tired of giving them month after month after month, twice a week regime, and they can, afford that one too, time-wise and cost-wise, then I might phase down to once a week after they are in deep CR or MRD negativity. Now, it's a different question when you're combining that with IMiDs. That is one situation where I would be very careful, because IMiDs, you can't deliver too much. The prescribed dose of 27 mg per meter squared, or at best 36 mg per meter squared, is possibly what I use, because in our Asian population at least, I think it's very, very challenging in terms of cardiovascular side effects when you combine with IMiDs. So I would be careful in that situation. With the CD38 antibodies, I think the dosing brings in a different side effect in terms of, so the cardiovascular signal doesn't seem to be there with the CD38, but the infection signal comes on. So again, I think I use a similar philosophy. Wherever possible, I use the original Equalia study dosing of 56 mg per meter squared twice a week, rather than the phase 3 dosing in a high-risk myeloma patient population, and then try to taper off as they achieve a deep CR and remain there for a while.
So as discussed, the selection of therapy in subsequent, in the first relapse and onwards, it depends upon the access to the daratumumab or carfilzomib, and depending upon the access, DRD versus KRD shall be the preferable option in LEN-sensitive patients, and for the LEN-refractory patients, DVD, DKD and DPD shall be the preferred options. So the goals of second line on therapy and onwards are we have to choose, we should prefer triplet regimens in these patients, and we should aim to select combinations that contain different classes or that have not been used for more than 6 months, and maintain patients on therapy until toxicity. So my question to Dr. Hari is there any role of ASCT at the time of first relapse, and is it only viable for the patients who have their cells collected prior?
Well, there is some data. The IFM had brought out the data of you doing ASCT at the time of second relapse, but their data showed that there was no real difference in the second relapse whether we used a salvaged regimen or used an autologous stem cell transplant. That's what the data has to say from the IFM group. But having said that, for a fit relapsed patient, it's not mandatory that his stem cells, it's not going to be a real problem with the availability of plerixafor, etc., to be able to mobilize the stem cells. But also sometimes if the patient has been on lenalidomide for a long period of time, like in the maintenance phase, we do not know whether there is going to be a challenge as far as harvesting is concerned. But having said that, it is an option in the second relapse, but the data would not be so impressive about doing autologous stem cell transplant over there.
So I would like to have your brief comment on the IFM 2009 and determination trials. So which side of the fence you are, early transplant versus delayed transplant?
So from a practical perspective, I think doing an early transplant is better, because most of the time if you look at the data again, the number of patients who actually went into in a pre-planned way to go in for a late transplant was far less than those who went in the initial transplant. So from a practical perspective, it is better, but otherwise it is It is essentially the same.
And do you cryopreserve the cells for all patients newly diagnosed?
Unless we are planning for doing a tandem transplant in these patients, which are very few and far in between, we are not currently harvesting and cryopreserving those stem cells. But it depends upon independent individual patients.
So I think there is
Sorry,
one...
could I just mention one point on your role of deferring transplants? I strongly would advise not to, wherever feasible. I think this whole discussion about difference or lack of difference in OS applies to a very Western context. They simply cannot show an overall survival difference because of the access to further therapies that they receive after they've relapsed second line subsequently. Whereas simply in our Asian setup, we don't have endless supply of novel agents after their first relapse happens. So if you do a study today in an Asian context of deferred transplant versus a frontline transplant, we will definitely be able to show an OS difference in our patient population. I think that's just not applicable in our scenario.
So as far as the feasibility of cryopreservation is concerned, so there is a recent study from ACTRAC at TMH Mumbai, where the cryopreserved samples were found to have more than 80% median viability at median duration of 6.6 years. So this is something very heartening from an Indian perspective. And coming back to the index case, the second line therapy somehow was Dara-POM-Dex for this patient for 12 months. And followed by Dara plus POM maintenance. And this patient achieved VGPR and progression at 20 months. Third line therapy was given in the form of KRD for 10 months. The patient achieved PR as the best response and progressed on KRD at 10 months. And there was no immediate access to CAR T-cell therapy. So patients with triple class